My name is Perla Cedillo, and I have a 57-year-old male patient that comes in today complaining of nausea and vomiting for the past 2 weeks. Chief complaint is that he started to feel sick to his stomach, and it's been progressively getting worse as the days go on. He denies any recent travel. The nausea is described as moderate, and the vomiting is intermittent. With just food particles in the emesis. Um, the vomiting has occurred several times today and has been dark in color, but it does not have any blood tinged particles, any coffee ground emesis, or frankly bloody emesis. Um, no black stools or bloody stools. No abdominal pain, no flank pain, denies any contact with sick individuals or change in routine, denies any recent treatment with medication like antibiotics, denies any kind of camping or does, however, report some possible bad food exposure. And the reason why he says that is because when he eats, the food just tastes bad. Has never had this in the past and has not been evaluated for this either. Um, Review of systems, he does not have any fever, no muscle aches or difficulty with urination, dark urine or headaches, no dizziness, sore throats, fainting episodes, no blurred vision, no ear drainage or pain, no jaundice, no congestion, no epistaxis, no runny nose or mouth sores, no toothaches or calf pain, no difficulty in breathing or pedal edema, no alteration in mental status or dizziness or headaches, denies any head injuries or numbness or weakness, no lymph node swelling, denies any sleep disorders or any difficulty in walking. Does report increase in thirst, states that he can drink all the water without quenching his thirst. Also noted some polyuria and some polyphagia. He has a medical history of GERD and hypertension and has a surgical history of femur repair in 2008. Currently, he does take Prilosec 20 milligrams, one pill by mouth every day for his GERD. Does not recall the blood pressure medicine he's supposed to be taking. Reports that he's not been taking it for the past 3 months. Just ran out and doesn't feel like he needs it. As far as his social history, denies smoking, denies alcohol use or illegal drug use. Family history, his father has hypertension and he's alive. His mother also has hypertension and diabetes. Fraternal grandfather expired of an MI at 72. Fraternal grandmother expired in a motor vehicle accident. Maternal grandfather expired of unknown causes, but he did have COPD. And his maternal grandmother is also expired of uterine cancer. Vital signs for this individual upon physical exam, I show a blood pressure of 161/74, heart rate of 90, respiratory rate of 20, saturation 99% on room air, temperature of 97.9, and denies any pain. He is alert and oriented times 3. He is in no acute distress, but does appear anxious. His eyes, pupils are equal round reactive to light, normal inspection, no conjunctival findings, ears are normal, nose, oral mucosa, pharynx, all of that is normal. Neck is also normal to inspection, no lymphadenopathy. Cardiovascular system, he does have a normal heart rate and rhythm. Heart sounds are also normal, pulses are normal and present. Respiratory rate or respiratory system, he's in no distress. Breath sounds are normal and clear to auscultation to all lobes. No accessory muscle use, decreased air movement, rales, rhonchi, or wheezes. His abdomen is soft and non-tender. Bowel sounds are present in all 4 quadrants, no masses. No abdominal tenderness, rebound tenderness, distension, or any kind of masses present. He does have some striae in his abdomen, and it is pendulous. Bowel sounds are normal, like I said. His back is normal to inspection, no tenderness. The skin is warm and dry, no rashes, normal skin turgor. Extremities exhibit normal range of motion, no calf tenderness or lower extremity edema. Neuro-wise, he has GCS of 15. Um, he has no alteration in mental status. He answers all questions appropriately. No cranial nerve deficits, no motor deficits or weaknesses, no sensory deficits, and reflexes are normal. As far as diagnostics for this patient, because of the symptoms that he described with the increase in thirst, the polyuria and polyphagia, um, and the fact that he's not really compliant with his hypertension treatment, um, we went ahead and drew a glucose, an in-office glucose, and it showed 348. So he's a new onset diabetic type 2. So for him, we went ahead and got a CBC, um, comprehensive metabolic panel as well, and a UA. The UA in office showed glucose of 500 and a moderate bilirubin and ketones of 40. We don't have a hemoglobin A1C on file, so we went ahead and drew that just to establish a baseline and to establish goals for him, especially because he's going to be started on medication, oral, and then hopefully some basal insulin eventually. His EKG was normal, and also we went ahead and drew a liver function profile. As far as the management and plan, so the key here is lifestyle modifications. The key is to have him truly understand the importance of managing his hypertension, and now the importance of managing his diabetes. So diet, exercise. So start him on a program where he can slowly work himself about 3 to 5 days per week, 30 minutes, initially, and then work his way up. And also set some weight reduction goals. So the idea is to have him lose anywhere from 10 to 20 pounds. Of course, realistically, once he's on his medication and once he is seen by additional members of the team, he can accomplish that. The patient's also going to be given a script. So as far as his diabetes is concerned, he's going to be sent home with a script for a glucometer and glucometer strips. Home health services are going to be set up in order to have a nurse go out and teach him how to check his sugar and also teach him how to begin a log. So the idea is to have him check his sugar, breakfast, lunch, and then right before dinner. So 3 times a day. And keep a log of this, which the patient's going to be asked to bring back to the next visit. Also, skin checks are important to make sure that we don't have any wounds or sores that develop, and to teach him how to do that is also something that the home health nurse is going to be responsible for. I'm going to go ahead and get him started also on metformin. So metformin 1,000 milligrams PO by mouth twice a day until we have the hemoglobin A1C, and then we could possibly get him on some basal insulin to get his glucose under control. As far as his hypertension, he's not been on any medicine for some time, so it's important to get him started on an ACE inhibitor. So go ahead and get him on lisinopril 10 milligrams by mouth, one by mouth every day. And also get him to start that log. So a blood pressure log where he records his blood pressure 3 times a day for the next week that he's going to bring back to his next appointment in order for us to sit and evaluate exactly what's going on with those blood pressures. Evaluation for hyperlipidemia also must be done. So once we get those results for that liver function profile, we can possibly get him started on treatment or just kind of watch and wait. For his GERD, he's going to remain on his current treatment plan since he doesn't report any like new GI complaints. But possibly, if that does change, then we could get him sent over to a GI specialist. For the nausea, Sofran 4 milligrams is appropriate. So 1 tap by mouth every 4 hours for the next 3 days. As far as a follow-up, I would like to see him in a week from today to sit down and evaluate that blood pressure log and then the glucose, the at-home glucose reading log. Once he's stable and his hemoglobin A1C is where we want it, and he's losing weight, we're going to follow him every 3 months. In the meantime, though, it is key that he be referred to a dietitian for meal planning.